Actually, I have to make a slight correction. It's in April that I will join the 10% of women across the country who are full professors on faculties of medicine. And I thank so many members of FAMWA who have actually helped to get this done. I went up on a service line. So Dr. Carr and Dr. Abul, the work that you've done over the years actually has made a significant impact, and it has allowed me opportunities to speak across the country. And speaking at a national meeting like this does help in your promotion. But it also helps when you can meet people like Dr. Abul, who actually we met giving a talk together a year or so ago, and who wrote one of my letters of recommendation for me to go to full professor. This is not an easy task, but it's a really important task. We need to be more than 10% of full professors. And at IU School of Medicine, when I become a full professor in April, I will be one of 2 underrepresented minorities who are full professors at that level. 2. We have to change that. But I'm here to actually talk to you about eating disorders. I do internal medicine in adolescent, and part of my clinical role is to do eating disorders, especially in adults. Everybody here knows somebody who has had an eating disorder, whether you've treated them in the office, whether they were your roommate, or a family member. We want to raise the awareness of eating disorders in general. We want to encourage folks to at least ask the question. If we don't ask the question, if we don't screen, then we won't know. Doing that right? There we go. So I ask you all to take home just 2 simple questions and ask these in your offices, in your general medicine offices, in your primary care offices, wherever you are. The first question, are you comfortable with your current body shape and size? Now, most of us will have something we don't like. If we have straight hair, we want it curly. If we have curly hair, we want it straight. We're never really happy. But when you ask, are you comfortable with your current body shape and size, and what you get is no. What parts of you do you like? None of it. Those are important things. The second question, what have you done in the last year to try to change it? Especially important for our younger folks who try to lose a few pounds and don't quite know how to do that. So what have you done to try to change that? And get some fairly specific ideas. One of our inclusion questions is a 24-hour diet history. I want to know, what did you have to eat yesterday? When your patient can say 4 almonds, 3 raisins, 1/2 cup of rice, and a head of lettuce, when they can document it that well, that quickly, that should send off warning bells. And even if they give you an idea, you have to then kind of delve in a little bit more. For example, 2 patients. One, my anorexic patient. What did you have to eat yesterday? Turkey sandwich. What was in that turkey sandwich? Well, it's a slice of bread and one slice of turkey meat, no condiment. And she didn't even eat all the bread. My obese patient, 400 pounds, and I said, what did you have to eat? And he told me a turkey sandwich. His wife hit some, tell her how you made that sandwich. It's a loaf of bread, 3 pounds of turkey, and a jar of mayo. There's a big difference in what is incorporated into an element of food that they're eating. So I try to ask those specific things. Why do we ask this? Well, one, because we know that 91% of college-age women have been on a diet within the last 2 years. And so think about yourself. A diet is something that you go on and off of. I try to not think of diets. I try to think of meal plans. I try to think of, I love the choosemyplate.gov because Choose My Plate gives you an idea of what we're supposed to be putting in every day with every meal to give you some idea. All the other quick weight loss things just encourage eating disorders. We know that 35% of dieters develop pathological dieting practices. This is the reason why the screening question is, what have you done in the last 2 years to try, what have you done to change your body shape? And you have to be fairly direct. Think about yourself. When you go to lose those few pounds for something, a wedding, a prom, or something, the first thing you do is skip. You skip a meal. You skip a meal, pretty soon you start to get really hungry, and then by the end of the day, you are binging and overeating. So we set up a nasty habit of restrict, 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 binge, binge, binge. I'm so guilty about that. Why did I do that? Purge, purge, purge. So a meal plan is something that we devise so that you can eat in a healthy way and learn how to put the proper nutrition into your body rather than trying to eliminate things. One of the hardest lessons that I had to learn coming into working in eating disorders is that there is no bad food. There is no bad food. It's the way that we interpret that food. It's the way that we deal with that food that brings about good and bad. And it's a little schizophrenic because half of my time I work in general medicine and the other half I work in eating disorders. And it's really hard when my patient with diabetes who's got the hemoglobin A1C of 10 comes in with their large Mountain Dew that's not sugar-free. I dump it in the sink because in that office, that's a bad food. But when I come to my eating disorder office, there is no bad food, and it's just the choice that they make to have that stupid large Mountain Dew. And I want so bad to go, what are you thinking? But no, it's about making appropriate choices all day, every day. And if you have something extra, be mindful about it and darn well enjoy it. So for many, we think that this is not a very common thing. It is. It is. Now, granted, your lifetime risk for developing an eating disorder, especially anorexia, is only 0.6%. Yes, it's true that the majority of eating disorders develop during adolescence. However, we looked at our patients, our adult patients over the age of 25 at the Carr Center, where we see 14,000 patient visits per year, and we looked at all of those adults and found that over 50% of the adults with eating disorders presented as an adult. They did not have the condition when they were younger. And for some, especially for adults, there were a multitude of reasonings for why it happens, some of them very similar to what happens when you're an adolescent. But for most of the adults, there was something that happened. There was a divorce, there was a change of life, there was a job change, or I just wanted to lose. I'm tired of people, yelling at me, and then once they started losing, they just couldn't stop. Or they started in a new career where they had to do a lot of meetings and they felt uncomfortable with what they were eating and they started purging to kind of get over it. Along with the typical anorexia, which is mostly restriction, bulimia, and bulimia partly again too, because I didn't want to have to do all that. You were watching me eat it, so I went home and got rid of it. Bulimia can also be laxative abuse, and it can also be diuretic abuse. Binge eating disorder is probably one of the ones that I see most common in adults. And it's that inability to stop yourself, or it's the way that you make yourself calm. So instead of going to the bottle, you go to the food. You remember how you feel after Thanksgiving? You're all nice and calm and kind of tired. Sometimes that's the effect that you're looking for with binge eating disorders. We know that 1 out of every 200 women have at some point had some relationship with anorexia, and a fair number suffer from bulimia. And it's not just an either or, it's a combination. And in fact, what we see so many times is the treatment for one disorder gets resolved, and then the next kind of starts. So the anorexia gets fixed, and then it's the bulimia. We also know that 30% of patients with eating disorders have suffered some degree of abuse, whether it be verbal, sexual, or emotional. So when those conditions have occurred, it needs to be treated as soon as possible so that you can avoid the complications that arise. I think actually that one of the very first written documentations of anorexia was Princess Margaret of Hungary. Princess Margaret of Hungary became a saint. She was given to the convent when she was 4. And if you really read her biography, she did a lot of fasting, i.e. restriction, sleep deprivation. She worked really, really hard. If you look at some of our anorexics, they're always moving because there's a way of using up your energy, and you can use up calories just by sitting because you're always moving. She also did some self-flagellation, so self-injurious behaviors. For her, theoretically, it was all in the name of God. It doesn't really matter what it's in the name of, it's still disordered behaviors. Bulimia itself is recurrent episodes not only of binge eating, but then also of purging, of getting rid of it, whether it be by vomiting, whether it be by laxative abuse or others. It's a recurrent, inappropriate response, and it's a sense of lack of control. There is this feeling of you can't stop it. One of my patients would eat a box of crackers, and every time she noticed, she would start, and then she'd count out the crackers again. Oh, that one's not the same number. Oh, I have to do it. So she kept going until she could get them even, but she could never get them even because she couldn't stop herself from eating the next one. It could be bowls and bowls of cereal at one time. It's that sense of you can't really stop doing it, and it usually goes on for at least a few months. The binge eating disorder is recurrent episodes of massive quantities of food. Usually binge eating disorder actually starts at the age of 16. And it starts at the age of 16 because why? You get your driver's license. When you get your driver's license, you can go through the drive-through. You don't have to get out of your car. People don't have to judge you when you walk in to buy something and say, why are you buying that Big Mac and fries, you big lardo, you know? You can go, as you go through the drive-through window, you can get more. You can get it, eat it in your car, and throw away the evidence before you ever get to your house. With laxative abuse, be cautious. Most people will not tell you about their laxative abuse. They don't tell you. You have to ask them very specifically. But if you had noticed somebody with low potassium levels for unclear reasons, this would be one of the reasons why. Or somebody, a young person especially, who passes out for no good reason, we need to be asking about laxative abuse. Now, I wanted to speak just briefly about orthorexia. So I had a patient who came in on the advice of her physician and said, when is it, when did it become a bad thing to eat right and exercise? Well, when you missed picking up your children from daycare because you were running, when you get up at 4 o'clock in the morning to do 3 to 4 hours of exercise before you go to work, when you restrict what you eat because you can't be sure if it's really healthy or not, such that at 6'3", you weigh 80 pounds and sleep in the operating room in between cases, that's orthorexia. Every day you struggle so hard to just eat the right things that you become very obsessive. So even good behaviors can lead to very bad outcomes. The treatment for eating disorders is very multidisciplinary. It takes multiple different ways of taking care of this. But the biggest thing that I wanted to get across is really 1, screen, 2, you're not alone, and there is some recovery. Yes, we can get people to recover. Yes, they can improve. And appropriate treatment, early treatment, is the best option. Thank you.